We'd like to welcome all of you to Mary Overby's world film premiere debut. It is not at the Cannes Film Festival in France, although that is where she'd like to be. But we do want to thank her very much for volunteering to be our first training video. She did volunteer. I keep overlooking that part. We do have one phenomenal volunteer so far, and that has been Jim Musselwhite, who has posted some wonderful videos, although we may have to rewrite our definition of training at this point. However, with that said, we're here to talk about some orders and intake issues that we're running into, and these are sizable. We're starting with our biggest issues in our first video and moving from there. And this is our intake for Medicare oxygen patients. This is an area where we are getting audits on pretty much every patient, or expect to get audits on pretty much every patient at this point. Mary, how many audits have you opened this week?
72.
72 audits. So that is, that's a part of life at this point. When Medicare contractors are told to run a lot of audits, that's what they're going to do. It's not that anything that we're doing is wrong, but it does mean that everything we do on the front end has to be exactly right. So Mary's going to review the three biggest issues that we're running into with intake on Medicare oxygen patients.
Thank you. The biggest three issues that we are having right now with oxygen intake, starting with the first one, is our qualifying oxygen SATs. The SATs must be within 30 days of our initial setup date. The qualifying SAT at rest is 88%. We can use 89%, but the patient will have to be retested within 90 days of that SAT. The qualifying at exertion is the biggest problem we see. There are three SATs that are required to qualify a patient at exertion. You have to have the room air at rest, you have to have the room air at exertion, and you have to have the oxygen at exertion SAT, which means that they have to be on oxygen at the prescribed level while they're at exertion. Also qualifying during sleep is a major issue that has to be done while the patient is in a chronic stable state. This means that if we're qualifying a patient for oxygen and they have OSA, then they have to be on their prescribed CPAP level while they're desatting. They also, if we're going to prescribe a patient, or if we're going to deliver a patient oxygen and they're not prescribed a CPAP machine for their OSA, then our oxygen SAT overnight has to be at a test for at least 2 hours, and the SAT has to drop for at least 5 minutes during that test. There are no sleepwalkers, so if we're qualifying a patient overnight, there's no need to deliver a portable system of any kind. Prescriptions, qualifying oxygen prescriptions have to have the patient's information, the prescribed treatment, the date, the doctor's name, the NPI number of that doctor, which you can add if the doctor does not have that on their prescription pads, and the doctor's signature. It cannot be signed by a nurse. It can't be prescribed by a social worker or a caseworker from the hospital. The prescriptions for oxygen cannot have PRN or as needed. They have to show the liter flow. It has to show the route, which is nasal cannula or by mask, and the frequency, which is usually continuous or at night. Finally, the 30-day evaluations. All patients have to be evaluated by a physician within 30 days of us setting them up. That is prior to our initial date of service. Per Medicare, if we don't have an evaluation within 30 days, then the SATs are not valid. So please make sure that these notes are in the patient's account before you try to set them up, or that we at least have the date of the evaluation. For overnight qualifying, we will be requiring that we have the 30-day notes prior to confirming the orders. And if there are any questions about any orders, please call us here at the corporate office. We'll be glad to answer any questions. Thanks.
To review on this, we've got to have the right SATs, and so you've got orders coming in that we don't have the right O2 SATs.
That's correct.
Or you may have orders coming in and it may have an O2 SAT on the prescription, but there's no notes where anybody shows that they actually tested the patient.
Correct. And we have no way of knowing where or how that SAT was taken if all we have is 88% on the prescription.
So that there has to be supporting documentation that shows how they tested the patient. And if we don't have that documentation for how they tested the patient, then somebody just writing a SAT on a prescription doesn't demonstrate that. That will actually lose in an audit, and that's one of the things they're running into. If it is overnight, as Mary said, if they only need it overnight, then there's no reason for them to have a portable system. Or if it's only at sleep, there's no reason for them to have a portable system. And we do see orders where there's portable systems on there, even though there's not one that we can medically justify. Checking the prescription, making sure it's got everything it needs. You know, even if a physician writes a prescription for any other medicine, for headache medicine even, they're going to tell the patient how many times a day to take it. They're going to put on there whether it's a pill or a liquid, if it's taken orally or intravenously. So this is very much the same as their prescription writing process throughout. And finally, to review, when Mary talks about them having to have a 30-day evaluation, you have to have the physician discuss their therapy with the patient. You know, we cover with the patient how to use their equipment, but it is the physician who still has to fully discuss their therapy. So if through an overnight test they find out that they need oxygen, and maybe the physician says, okay, we got to go ahead and get them set up, and we do, they still have to go back into that office and discuss it, because he may be a week from when he can get an appointment for them, but he feels like they need the oxygen now. But if we're going 30 days and they're not getting that follow-up with the physician, then all of that oxygen is nullified at that point. So Medicare is actually very reasonable in these audits and what they're looking for. We just have to make sure that we're very good about getting these in place. And the biggest help you can give us is that if it is oxygen for exertion, making sure that you have all 3 sats. If it is oxygen just at night, making sure there's no portable on there. And making sure that the prescription is clean and has everything it needs on it so that it is valid. We are losing some things on technicality and going back and winning them on appeal. But appeal at this point, depending on how far it goes, can take up to 3 years. So that is why that is a big deal. We hope that everyone has a good week. And Mary, thank you very much.
Thanks.